Good evening. I'm Kelly Geer Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining me this evening for our monthly webcast series, Healthy Conversations That Matter. A Women's Journey strives to improve your well-being through health education. According to the American College of Gastroenterology, gastroesophageal reflux disease, better known as GERD, is thought to affect up to 20% of the U.S. population. Tonight, we are joined by Johns Hopkins gastroenterologist Monik Lammi, who will speak about GERD. So please use the Q&A on your screen to ask your questions to Dr. Lammi, who will respond during the last 20 minutes or so of our program. Tonight, our webcast will conclude at 8 p.m. I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for the production assistance. You can visit their website, hopkins@home.jhu.edu, for additional lectures and courses throughout the year. A Women's Journey acknowledges the support of the Wiglicki Family Foundation, sponsor of Healthy Conversations That Matter. And now I am pleased to welcome Dr. Lammi. Hello, Dr. Lammi. Welcome.
Hello. Thank you so much for this opportunity to discuss this important topic. GERD is the most common GI disorder in the United States, and it can have a significant negative impact on patients' quality of life. It is an exciting time in this field as gastroenterologists and surgeons have been collaborating together both in research and in practice, and we now have a better understanding of GERD and have a variety of treatment options. But that can be overwhelming for patients, and I'm hoping that this presentation will help empower patients to make educated decisions about their GERD treatment. So my objectives today is to discuss symptoms and evaluation of GERD in adults, to help patients understand mechanisms and complications of GERD, and to review available treatment options. Acid reflux occurs when stomach contents back up into the esophagus or mouth. Occasional reflux is normal and may occur after eating a large meal. It's usually brief and not bothersome. Gastroesophageal reflux disease, or GERD, is when reflux symptoms become bothersome or acid reflux causes damage to the esophagus. GERD is the most prevalent GI disorder in the United States. It's estimated to occur in 20% of patients in the US. The prevalence is lower worldwide, where it's estimated to be about 13%. It's highest in South Asia, Southeast Europe, where it's estimated to be about 25%, and lowest in Southeast Asia, Canada, or France, where it's estimated to be about 10%. What's interesting that the prevalence has been increasing, and it actually increased by about 50% since 1999. In North America and in Europe, there's no association between sex and symptoms of GERD, but in South America and in the Middle East, women are more likely to report GERD symptoms. Men are at a greater risk for complications from GERD, such as erosive esophagitis, Barrett's esophagus, and esophageal cancer. In general, risk factors for complications of GERD include advanced age, male sex, white race, obesity, and tobacco use. GERD presents with two typical symptoms: heartburn, which means burning sensation in chest that may spread to the throat, and regurgitation, or feeling of stomach contents moving up the esophagus towards the mouth. Both of these typical symptoms are highly predictive of GERD. Patients may also have atypical symptoms, such as chest pain, discomfort in upper abdomen, belching, sour taste, difficulty swallowing, or painful swallowing. Some patients may experience symptoms outside of the GI tract, such as throat clearing, sore throat, sensation of lump in the throat, hoarseness of voice, chronic cough, wheezing, or even damage to teeth. What's important to remember that these symptoms are not specific to GERD and can be seen in other disorders. So what causes GERD? GERD occurs when stomach acid washes up into the esophagus and causes irritation. When we eat, food moves from the mouth to the stomach via a tube-like structure called esophagus. Then esophageal muscles propel the food by wave-like movement towards the stomach. At the very bottom of the esophagus, there's a valve called lower esophageal sphincter. This valve is very important in GERD. This lower esophageal sphincter functions as a one-way valve. It opens to allow food into the stomach and then closes to prevent food and acid from backing up into the esophagus. The lower esophageal sphincter is strengthened by a muscle called the diaphragm, which separates the chest from the abdomen. Sometimes this valve fails, allowing liquid from the stomach to wash back up into the esophagus. Hiatal hernia often plays a role in GERD. The diaphragm muscle that separates the chest from the abdomen has an opening in it where the esophagus passes through it before it joins the stomach. That opening is called the diaphragmatic hiatus. When this hiatus becomes large, part of the stomach moves through this opening into the chest, and as a result, the diaphragm is no longer strengthening the function of the lower esophageal sphincter because it's no longer aligned with the lower esophageal sphincter muscles that are located at the bottom of the esophagus. So the acid reflux becomes more frequent. GERD is usually not dangerous, but it can be very uncomfortable. And poorly controlled GERD can, in fact, damage the esophagus. It may cause ulcers, also known as erosive esophagitis. Erosive esophagitis can be identified in about a third of patients that have reflux. And it is classified based on Los Angeles classification, where grade A erosive esophagitis is mild reflux with very little irritation seen at the bottom of the esophagus. And this can progress all the way to grade D, which is severe esophagitis, where large white ulcers are visible at the very bottom of the esophagus. GERD can also lead to strictures of the esophagus, where the prolonged acid exposure causes scarring and eventual narrowing at the bottom of the esophagus. Another complication of GERD is Barrett's esophagus. This is a precancerous condition which occurs when the lining of the bottom of the esophagus heals abnormally. And the cells in the esophagus start to change. These cells go from cells that look like esophageal cells to cells that look like intestine. This can be suspected on endoscopy when the lining has pink, irregular salmon-colored appearance compared to the normal white color appearance. And then we can confirm it with pathology, where under microscope, we can see that cells have intestinal metaplasia, which means that the cells look like intestine cells. Prolonged acid exposure at the bottom of the esophagus may cause progression of Barrett's esophagus to cancer. This is called dysplasia or precancerous cell growth. So Barrett's esophagus starts as non-dysplastic Barrett's esophagus, and then slowly over a long period of time progresses to low-grade dysplasia, then high-grade dysplasia, and then esophageal cancer. This is a rare complication overall of GERD. Patients may also develop complications outside of the GI tract. If the stomach acid backs up all the way to the throat, patients may experience sore throat, inflammation of the vocal cords, or voice changes. If the acid backs up into the mouth, patients may experience damage to their teeth. And if the acid backs up all the way into the lungs, it can cause cough, pneumonia, or asthma symptoms. And over a long period of time, it can even lead to lung damage. GERD may be diagnosed based on symptoms specifically those typical symptoms of heartburn and regurgitation, in which case the healthcare provider may suggest a trial of medication. GERD is likely if the symptoms improve with this treatment. But sometimes additional testing may be necessary, especially if there's no improvement in symptoms with acid-suppressing medication, if the symptoms are not classic and the diagnosis isn't clear, or if the symptoms suggest another problem, or if patient has risk factors for complications like family history of cancer or the patient is a smoker. It's important to be aware of alarming symptoms. These symptoms include painful swallowing, difficulty swallowing, weight loss, poor appetite, GI bleeding, recurrent vomiting, or severe stomach pain. These type of symptoms warrant prompt evaluation. We usually would start evaluation with EGD, or esophageal gastroduodenoscopy, which is an endoscopic procedure that allows the doctor to examine the upper GI tract. In this procedure, a small flexible tube with a camera is passed through the mouth into the esophagus, stomach, and the duodenum. Duodenum is the early part of the small intestine. Some patients may require objective acid reflux testing, and these tests include Bravo and 24-hour pH impedance. During this test, the patient also documents in a diary when they're having symptoms, and we're able to correlate if patient actually had acid reflux event when the symptoms occurred. With Bravo wireless pH testing, a small capsule that's about the size of a pencil eraser is temporarily attached to the lower part of the esophagus during an endoscopy. The capsule spontaneously disconnects within 2 weeks, and the sensor probe in the capsule records acid level in the bottom of the esophagus. The patient wears a recording device that communicates with the sensor, and the data is used to assess the severity of reflux. This test is carried out over 48 to 96 hours. An alternative acid reflux test is 24-hour pH impedance test. During this test, a narrow flexible tube called a catheter is inserted into the nose and extends to the stomach. The catheter delivers data to a small computer, and the doctor uses the data to assess severity of reflux. With this particular test, we're able to assess for acidic reflux, weakly acidic reflux, and non-acidic reflux. This test lasts 24 hours. Some patients may require esophageal manometry. With this test, a thin catheter or flexible tube is placed into the esophagus through the nose. This test measures motility or the muscle movement of the esophagus. It lasts about 30 minutes. This test is not used to diagnose reflux, but it's used in combination with pH impedance in order to identify where to place the acid reflux pH catheter. And it's also used to assess for weakness of the esophagus and to help identify other disorders that present with symptoms similar to acid reflux. So how do we treat GERD? Usually we start with lifestyle changes. For instance, losing weight if a patient is overweight. And that's important because studies show that losing 10% of body weight can have a significant improvement in GERD symptoms. We encourage patients to quit smoking. And there are some other changes that can be done for nighttime reflux, like raising the head of the bed about 6 to 8 inches is usually sufficient. This allows gravity to prevent regurgitation of acid. This is not supposed to be done with pillows because pillows don't usually work, but you can put blocks of wood under the legs or a foam wedge over the mattress. Some studies have shown that sleeping on the left side can also prevent reflux at nighttime, and there are devices that are available that can help keep a patient in that position. And then, of course, avoiding eating for 2-3 hours before bedtime is helpful so that whatever food is in the stomach doesn't move up to the esophagus when the patient lays down. Patients can also make changes to their diet, and these include avoiding alcohol or avoiding foods that traditionally trigger reflux symptoms. These foods include fatty or fried foods, chocolate, caffeine, alcohol, mint, garlic and onions, citrus, juices and fruit, and carbonated drinks. When lifestyle modifications are ineffective, patients often turn to antacids, which are available over the counter, such as Tams or Maalox. These medications neutralize stomach acid, but they are very short acting and don't have a benefit for a very long time. Other medications that are available over the counter are alginates. This includes Gaviscon. Alginates create a floating barrier in the upper part of the stomach, preventing acid from moving into the esophagus. Alginates tend to have a longer effect on symptoms. Histamine receptor antagonists, or H2 blockers, are another great option to help with acid reflux. These medications work by blocking histamine receptors on acid-producing cells, reducing production of acid in the stomach. These are medications like cimetidine or famotidine. These are available over the counter, but can also be available as prescription. And they are longer lasting than the other over-the-counter medications. The most popular class of medication is proton pump inhibitors, or PPIs. They work by reduce acid by blocking acid production in the proton pump in the stomach. These are more effective than H2 blockers. They're supposed to be taken about 30 or 60 minutes prior to a meal, either breakfast or dinner. And there's a variety of different PPIs that are currently available in the United States. Some of them are stronger than others, and some of them are available over the counter, and some require a prescription. There's been a lot of controversies about PPIs because some studies have shown possible association between long-term use of PPIs and development of adverse conditions. So studies have suggested possible risk of intestinal infection, pneumonia, stomach cancer, osteoporosis, fractures, chronic kidney disease, deficiencies in vitamins and minerals, heart attacks, strokes, dementia, and even death. Now, all of the studies that have mentioned these adverse conditions have flaws and do not prove that PPIs cause these conditions. And in fact, recent high-quality studies have found that PPIs do not significantly increase risk of any of these conditions except for a small risk of GI infection. Nevertheless, we can't exclude the possibility that PPIs might lead to a small increase in risk of adverse conditions. But in general, gastroenterologists agree that PPIs are very effective at controlling acid, and patients that have a strong indication to use PPIs should continue to use them, but use them at the lowest effective dose. Our leading organizations in GI suggest that providers should carefully review indications for PPI and discontinue PPIs when they're used without a good indication. When discontinuing PPI, it's important to be aware of rebound acid hypersecretion. So when discontinuing PPI that has been used for a long period of time, that may result in temporary increase of acid production in the stomach. In that situation, it's recommended to taper the PPI slowly and gradually decrease the dose over a longer period of time and use antacids in order to help with symptoms during the taper. The newest class of medication that has recently been introduced in the United States is potassium competitive acid blockers, or PCABs. These medications bind to potassium ions and block the pump that makes acid in the stomach. They are very effective at reducing acid. The medication specifically is vonoprazan, and this was approved in the United States in 2023. But these meds have been available in Asia for several years. Now, some patients may want to consider anti-reflux procedures. And there currently are few different anti-reflux procedures that have high quality evidence supporting their use. And this includes fundoplication, transoral incisionless fundoplication or TIF, magnetic sphincter augmentation or MSA. There's really no one procedure that fits all patients. And when expertise is available, patients should ideally be offered a spectrum of these options. A physician should help patient understand the risks and benefits of these procedures so that patient can feel comfortable deciding what is the best procedure for them. And next, I would like to go over some details about the risks and benefits and indications for these procedures. So fundoplication means folding of the fundus, meaning taking the tissue at the top of the stomach and wrapping it around the bottom of the esophagus. The principles of fundoplication include first fixing the hiatal hernia. As we discussed previously, hiatal hernia often contributes to reflux. So the surgeon will push the stomach that has migrated into the chest back into the abdomen, and then decrease the size of the opening of the diaphragm in order to prevent the stomach from migrating back up into the chest. And next, the surgeon would wrap the top part of the stomach around the lower end of the esophagus in order to strengthen the lower esophageal sphincter valve. There is a variety of different fundoplications. There are a variety of fundoplications that are available. Nissen fundoplication is the original fundoplication where the fundus wraps fully around the esophagus. There are also partial fundoplications such as door fundoplication, where the fundus wraps partially around the front of the esophagus, or toupee fundoplication, where the fundus wraps partially around the back of the esophagus. All of these have similar success rates, although the partial fundoplications are associated with less difficulty swallowing, less gas and bloating than the traditional Nissen fundoplication. Fundoplication can be done by an open surgical approach. In this approach, a patient will have one large incision or cut in the upper abdomen. This technique has been available since 1950s, and it's associated with longer recovery. Fundoplication can also be done with minimally invasive surgical approach or laparoscopically. In laparoscopic minimally invasive approach, small instruments are inserted into the abdomen via small incisions. This is the most common approach and has been available since 1990s. It is a preferred approach because it's associated with less pain after surgery, faster recovery, and smaller scars. So why would we do a fundoplication? It's indicated for patients with chronic reflux symptoms, patients that do not want to continue acid suppressive therapy, and patients that have failed medical therapy. But what we know is that patients that do really well with surgery are patients that have those typical reflux symptoms of heartburn and regurgitation, patients that respond well to medication, patients that have severe erosive esophagitis, and patients that have abnormal acid reflux testing. Patients with atypical symptoms of reflux, like asthma, chronic cough, laryngitis, hoarseness, are less likely to benefit from this surgery. And it's important to also know that this surgery does not prevent progression of Barrett's esophagus to cancer. In terms of the outcomes, most patients have improvement in GERD symptoms. Some symptoms come back months or years later. And in studies, many patients eventually resume PPIs. PPIs frequently in these studies have been prescribed for other diseases, and that doesn't necessarily indicate that surgery has failed. Overall, fundoplication is considered a safe procedure. But as with any operation, complications may occur, and these include bleeding, injury to surrounding organs, or infection. Some patients experience difficulty swallowing, which can occur up to 11% of cases, in 11% of patients. And this usually improves in 1 to 3 months. Initially, patients are put on a liquid diet for weeks after the surgery, and then they gradually advance diet as tolerated. Some people may need a procedure to stretch their esophagus. Patients also report difficulty belching or vomiting after this procedure, or bloating and increased flatulence. Some people may need a second surgery, and that's up to 5 to 10% of patients. And this can be done because of difficulty swallowing, because of reflux, or recurrence of hernia. It appears that over time, the need for surgery increases. And unfortunately, success rate of that repeat surgery is usually lower than the first surgery. Transoral incisionless fundoplication, or TIF, is a new exciting approach to fundoplication. Transoral means through the mouth without any external incisions. And fundoplication means folding of the fundus to prevent the stomach acid from coming up into the esophagus. In this procedure, a special TIF device is used to recreate the valve between the esophagus and the stomach, so it becomes a better barrier against reflux. The very first TIF device was FDA approved in 2007, but this device, as well as the technique, has evolved drastically and improved over time. TIF is indicated for patients that have GERD, patients with some improvement with acid suppressive medications, patients that do not want to continue PPIs, and patients who do not wish to undergo surgery. Traditional TIF is recommended for low-grade erosive esophagitis, such as grade A and B, and for patients that have a hiatal hernia that's less than 2. The newest version of TIF, called C-TIF or concomitant TIF, is a new modified approach that combines laparoscopic hiatal hernia repair and TIF, and this can be done in patients that have a hiatal hernia. It is not recommended for patients with severe esophagitis, esophageal strictures, and abnormal esophageal anatomy. Most patients experience improvement in symptoms and quality of life. Symptoms relief typically lasts 8 to 10 years, which is similar to surgery. Most patients have improvement in their GERD testing, and most patients were able to reduce or stop acid-suppressing medication. Generally, it's considered a safe procedure. Minor complications may occur, but they're usually temporary, and that includes chest or abdominal discomfort, shoulder pain, or sore throat. Serious complications occur in less than 3% of patients, and that may be a tear, bleeding, lung injury, or infection. And the newer studies, since the technique has been perfected and improved significantly, show even a lower rate of complications. Another exciting surgical approach to reflux is magnetic sphincter augmentation, or MSA, also known as Link's reflux management system. In this procedure, a dynamic bracelet of magnetic titanium beads is placed in the distal esophagus laparoscopically to strengthen the lower esophageal valve. This technique has been approved by FDA in 2012. These magnets separate to open up the bracelet and permit passage of food, and they also allow belching. The magnets can be removed if necessary, and putting in the magnets does not alter the stomach anatomy, unlike the fundoplication where the stomach is manipulated and twisted around the esophagus. Magnetic sphincter augmentation is indicated for GERD that has been confirmed by acid reflux study. It's contraindicated in patients with allergies to metals, such as titanium, stainless steel, or nickel, because that's what's included in the device. It is generally not recommended for patients that have difficulty swallowing or have poor esophageal function, patients with severe esophagitis, patients with esophageal Barrett's esophagus or esophageal cancer, patients with large hernia, or with esophageal strictures. It's important to note that despite the fact that the device is made out of metal, patients can undergo most MRIs. Most patients have improvement in GERD symptoms and quality of life, and most patients stop the acid-suppressing medications, and they also have significant improvement in GERD testing. The benefits usually last for more than 5 years. When compared to PPIs, studies have shown that they are better than PPIs at controlling regurgitation, which makes sense because PPIs reduce acid in the stomach but don't do anything to prevent the liquid from moving up into the esophagus. Patients are also more satisfied with this treatment when compared to PPIs. When compared to surgery, specifically fundoplication, they were found to be similarly safe and effective, but have less bloating. Patients report that they're able to belch and vomit. And overall, it's a less invasive procedure because it does not alter the stomach. So it's associated with quicker and easier recovery. It's usually done as outpatient, and most patients resume a normal diet the day after the surgery. However, it is associated with more difficulty swallowing than fundoplication. In terms of adverse events, it's considered very safe, and only rare complications occur during surgery, and they include bleeding, injury to surrounding organs, or infection. When it comes to difficulty swallowing, it can occur early or late. Overall, over a long period of time, it's actually similar rate of difficulty swallowing to fundoplication. There's a similar chance of needing device removal as needing repeat fundoplication surgery. And need for device removal does not increase over time. There is a small risk that the device may erode into the GI tract. And about 3 to 7% of the magnetic sphincter augmentation devices are removed. That can be accomplished endoscopically or by surgery. And during the removal, it's possible to change to fundoplication. And most surgeons believe that it is easier to remove a link system and create a new fundoplication than it is to repair a failed fundoplication. So in conclusion, GERD is the most prevalent GI disorder in the United States, with prevalence estimated in about 20%. It occurs when stomach contents back up into the esophagus, causing bothersome symptoms or damage to the esophagus. Typical symptoms include burning in chest and regurgitation. The alarming symptoms are painful or difficulty swallowing, weight loss, poor appetite, GI bleeding, recurrent vomiting, severe stomach pain. Complications include esophageal ulcers, strictures, Barrett's esophagus, and esophageal cancer. Evaluation includes endoscopy, pH testing with either Brava or pH impedance, and manometry testing, which evaluates esophageal function. The treatments include first lifestyle modification. There are many medications that are available, such as antacids, alginates, histamine receptor antagonists, proton pump inhibitors, and potassium competitive acid blockers. There are also exciting anti-reflux procedures such as fundoplication, transoral incisionless fundoplication, and magnetic sphincter augmentation.
Great. Thank you so much, Dr. Lammi. Wonderful information and lots of information which leads us to many questions. But it sounds like it can be a complicated, I don't want to call it a disease, but the GERD can be complicated to diagnose. So would you recommend, so in the beginning when someone is having, because there's a lot of different symptoms like you mentioned that could be for so many other issues that somebody might have. So when someone's starting to feel these things, should they, start taking the antacids and doing all that, or should they, just really go to their doctor first and to figure out what's going on? Because I would imagine it would complicate things if you start taking, over-the-counter things and, seeing what happens. What would you suggest?
I think it's reasonable to start taking the antacids. I think the important thing is to identify alarming symptoms, because those symptoms indicate that there might be something more significant going on. So those symptoms would include difficulty swallowing, painful swallowing, weight loss, nausea, vomiting, pain, all of those. If you don't have those symptoms, I think it's reasonable to try over-the-counter medications and see how you respond. But eventually, it's probably a good idea to at least discuss it with the primary care physician who is going to help guide the patient.
Great. Good. Thank you so much for that. Okay, so we're going to get started here with our questions. And our first question is from Celine. And she'd like to know, if you treat symptoms of GERD and reduce symptoms of bloating and burping and acid reflux, can the esophageal tissue heal or repair itself in time?
Yes. So if we know that if we treat reflux with acid suppressing medication, we can heal that esophagitis. In fact, if we do a procedure, if we do an endoscopy, and we see that a patient has grade B, grade C, or D esophagitis, we actually start the patient on acid suppressing medication, and it is recommended that we repeat the procedure to assure that that esophagitis has healed. So definitely we know that the acid suppressing medications, especially the PPIs, can control acidity and help heal the esophagitis.
Great. Thank you. Good to know. Our next question from Stephanie. She would like to know, what strategies would you recommend for managing GERD while making lifestyle changes, particularly for patients who need to take iron supplements?
So I think lifestyle changes are important for patients that have mild GERD or patients that have severe GERD. And I usually recommend that patients make sure that they are elevating the head of the bed. They are not eating for a few hours before going to sleep, because that prevents anything that's in the stomach moving up to the esophagus at nighttime. And GERD often occurs at nighttime, and some patients are aware of it and others not. In terms of some of the dietary changes, I mean, quitting smoking if you're a smoker, losing weight, I think is probably the most significant one, because we know very well that increasing abdominal girth probably generates pressure on the abdomen, and it's increasing the reflux that comes up into the esophagus. And studies have shown that reducing weight by 10% will reduce symptoms. So that's an important one for people that are overweight. And then finally, we have some dietary changes that can be implemented where we can avoid things like chocolate, caffeine, citrus fruit or juices. But unfortunately, that is not necessarily supported by high quality evidence, and it's very patient specific. So I do always recommend that patients kind of pay attention to those particular foods that are known to trigger symptoms. And then just sort of, sometimes patients can work with a dietitian to work on their diet, but that's definitely not necessarily as effective as some of these other options that we have for treatment.
Right, so maybe keeping a journal.
Yes, I mean, but patients do keep a journal, and most patients are able, once they understand what the foods are, if they start paying attention, they can kind of recognize that symptom is triggered by that particular food.
Right. Yeah. And when you're eating out and stuff like that, to be careful, really look at what's on the menu, what the description of whatever it is that you're ordering, And if you recognize that, just use common sense on that. Would you also say just, I know that GERD can disrupt sleep, but but from what I've heard from many other things is that getting a good night's sleep is very helpful in managing most things.
Yes.
So I would imagine it's the same for GERD. Is that correct?
Well, so it's interesting because not getting enough sleep can exacerbate the symptoms of GERD without necessarily changing the degree of acid that comes up into the esophagus. This goes into this phenomenon of visceral hypersensitivity, where when our body is stressed, it kind of magnifies, the brain magnifies the sensations. So actually there's been studies that shown that when patients were sleep deprived, they reported more symptoms, even though they didn't have more acid in their esophagus. But in fact, I think GERD is a big disruptor of sleep, and I think that can lead to a lot of other affect other parts of the body, and
Right.
it can cause headaches. It can make people more depressed just because they're not getting enough sleep. And those two lifestyle changes of lifting the head of the bed and making sure that we're not eating anything except for maybe a little bit of water for 2-3 hours before we go to sleep can make a huge impact on those nighttime symptoms.
Right. Thank you. Yeah, that's kind of a tricky one because GERD can keep you awake, and you really have to, all the little tricks of the trade that you described earlier, with your head and being raised and your bed and so forth. So that's a hard one. But anyway, that's good information, though, that you just gave. Our next question from Anne, she'd like to know what type of infections can PPI cause? Like what symptoms and what symptoms would you notice and what's used to cure it? So it's kind of a three-part, and let me know if you want me to repeat that.
So in the study, the actual randomized control trial that looked at this, it increased risk of GI infections like gastroenteritis or C. diff infection. Some of these less quality studies have suggested it may also increase risk of things like COVID infection or pulmonary infections. But again, the data behind that is not of high quality. And most experts don't really feel that there's strong enough evidence to make that kind of statement about those respiratory infections.
Okay, great, thank you. Gagan would like to know, I have been taking Mounjaro for the last 12 months, which has caused chronic GERD. Is it safe? That's number one, and you can speak about that. And then, is it safe to take a PP1 long-term, or PPI, I'm sorry, long-term to counter these GERD symptoms from Mounjaro?
This is a wonderful question. A little bit complicated to answer. So these new obesity medications, GLP-1 medications, are really improving obesity tremendously. And but at the same time, one of their side effects, and they work because they affect appetite, and they do that by slowing down motility of the stomach. So the stomach and the GI tract in general gets a little bit slower, and that feeds back to the patient not to eat as much. So by doing that, there's more food that is in the stomach, and therefore that is more likely to cause reflux, especially in a patient that may have a dysfunction of that lower esophageal valve at the bottom of the esophagus. So we do often, in a patient that is experiencing this while they're taking one of these medications, we do treated with acid suppressive medications, and many patients do have an improvement, and I think that's a reasonable treatment option. The interesting thing that we still don't know, we don't have much evidence for it at this point, but we know that if patients lose weight, reflux naturally may improve. So it will be interesting to see what's going to happen long term for patients that, lose a lot of weight, and perhaps their reflux will actually maybe get better over time.
Mm-hmm. Right. I mean, it seems to make sense that it would, but I think when you're taking anything, right, if you're taking a weight loss drug like a Mounjaro for whatever reason, but you also are someone that has GERD, that's a very, very tricky thing to handle, I would imagine.
It is, but I think our initial response to these medications on the from GI perspective was a little bit negative because we were seeing a lot of GI side effects.
Mm-hmm.
But the evidence to support the use of these medications and the benefits, there's a growing body of evidence showing that these medications are really having tremendous positive impact
Great.
on patients' life.
Mm-hmm.
So I think my perspective on it has started to shift after I actually saw studies that show that
Mm-hmm.
cardiovascular risks improve and sleep apnea. The most recent one is one of these medications can be used for sleep apnea, which is related to obesity. So
Oh, right. Yeah. Yeah. Well, definitely when we get more data on that, we'll have to discuss that. Our next question is from Sue, and she'd like to know, it's a good question, can severe symptoms of GERD in a woman be mistaken or misinterpreted as a heart attack or vice versa?
yeah, that's a great question. And I think unfortunately that's true, and not just for women, but also for men,
Mm-hmm.
because one of the symptoms of GERD is pain in the chest or burning in the chest. And the typical symptom is burning, but some patients just describe pain in their chest. And when that symptom is present, it's very important to first make sure that the heart is okay. So whenever I see a patient that's gives me a symptom of chest pain or even chest discomfort, the first thing I want to make sure is that their heart is okay, because that's going to potentially be life-threatening.
Right. Yes, you want to rule out the most dangerous thing first. Yep. Thank you for that. Our next question, now I'm going to butcher this medication name. I'm not good on this. So this is from Teresa. She'd like to know, is it okay to take a half adult dose of pantoprazole? You can,
Pantoprazole.
yep, for long term, for 10 years or more.
So I think that goes back to what I was talking about when I spoke about PPIs.
Mm-hmm.
So if we do know there's been studies that are suggesting that there might be association with these medications and potential adverse conditions. However, those studies are not very high quality studies. They have a lot of flaws. They were really showing correlation, not necessarily causation. And the more high quality studies that have been conducted over a few years, not a super long time, did not show any significant increase of risks from any of these conditions except for the GI infections. But because these studies came out, it really kind of made all the clinicians start to think about, why are we even prescribing these medications? And I think that's the important thing here, is that for every time we're prescribing it or every time we're taking this medication, we have to feel confident that it's a really good reason why we're taking it. So if somebody has Barrett's esophagus and that may progress to cancer, that patient should be taking their PPI, because we know that PPI is going to help prevent that progression. Patient that is having esophageal stricture, where the acid comes up into the esophagus, burns it, and leads to narrowing, where food starts getting stick and it can't pass through. That patient needs a medication forever in order to prevent that from happening.
Mm-hmm.
The patient has severe ulceration that we can see on endoscopy. We know that that's not gonna go away without something suppressing the acid. Those are the kind of patients that really can justify using it for a long period of time. I think if somebody is having reflux and they're taking this medication and we're getting to the point where they have to take it for a long period of time, it's a good idea to do acid reflux testing with that pH testing, where we can see, is this reflux severe or is it mild? Is there anything else that we can do to kind of mitigate the symptoms before we can commit ourselves to a long-term PPI? But in patients where there is an indication to take these medications, at this point, from all of our leading GI societies and the guidelines that they have provided us, the recommendation is to continue to take them indefinitely.
Yeah, I mean, that's really wonderful advice and makes sense. Because you certainly, somebody who absolutely has to be on any of these drugs would be, I mean, you can't sit there and have, all of these horrible symptoms and ulcers and all that, and then, where it just makes your life miserable. So it's great advice. Thank you so much. There's a question too. If you have severe GERD, does that mean you have a greater chance of getting esophageal cancer or throat cancer?
I think if you have severe erosive esophagitis, yes. Not necessarily throat cancer. The GERD is associated with Barrett's esophagus, which happens at the bottom of the esophagus, not in the throat, and that slowly progresses into cancer at the bottom of the esophagus. So it's associated with esophageal cancer. So people that have ulcers that are really severe and there's something that's constantly, that acid is constantly irritating the tissue at the bottom of the esophagus, they are more likely to progress, because that irritated tissue is going to continue to change. And it's really that dysplasia or that change is what starts that cascade that leads towards cancer.
Great, thank you very much. Let's see, our next question. So, is there any research about the relationship between GERD and the microbiome?
That's a great question. So there is recent evidence that suggests that patients with GERD have different microbiome than patients that don't have GERD. And it is suspected that abnormal microbiome may lead to activation on some degree of inflammatory response that leads to GERD symptoms and the GERD irritation in the bottom of the esophagus. There's also evidence that probiotics may help decrease GERD symptoms. And more recently, there's even evidence that the microbiome may be playing a role in progression of Barrett's esophagus towards cancer. But at this point, these are very kind of early studies, and we need more studies to better understand how to apply this in clinical practice.
That's great. Thank you so much. It's funny because there was a couple of questions that came in that were just asking about taking a probiotic. And so you just answered that question.
Yeah, that's a very, very recent data. I think in the guidelines, we use guidelines where experts get together to make a statement to recommend what we should and should not be doing based on the evidence that exists. And unfortunately, the quality of this evidence isn't strong enough to make any strong recommendations. It certainly is okay to increase probiotics in our diet. I think we definitely should be eating diverse earth or vegetable-based foods so that we can better define our microbiome, because what really defines the microbiome is the variety of different foods that we eat. So certainly making those kind of alterations to our diet where we're eating more fruits and vegetables and different types of nuts and beans, I don't think, I feel comfortable saying that to patients because I don't think it's going to cause any harm. But to, take specific probiotics or to, do anything more drastic, it's still a little bit too early to make a strong statement about that.
Right. So things like yogurt too is probably a really great food.
Right, it's
Yeah.
okay to
That natural probiotic.
natural things
Mhm.
that we know that have probiotics in them and that are gonna make a healthy microbiome. I think there's no harm in it. Um, but time will tell, and I think this is a very hot topic right now, and I think we, you know,
Mhm.
in the next few years, we're gonna have a much better understanding of it, and we'll actually start implementing it in our practice then.
Mhm. Great, thank you. Our next question from Sandy. She'd like to know, does a hiatal hernia cause GERD?
Okay, that's a great question. Yes, it does. I'm gonna try to go back to my slides about hiatal hernia. So the way that hiatal hernia, so what is a hiatal hernia? There is a muscle called diaphragm that separates the chest and the abdomen. Within that muscle, there is an opening, which is called the diaphragmatic hiatus. In that opening is where the esophagus meets the stomach. So at the bottom of the esophagus, there's the lower esophageal sphincter, which is just muscle at the very bottom of the esophagus that opens and closes to prevent food from coming back up after it's swallowed. Now, when we have a hiatal hernia, part of the stomach, that opening, that hiatus is bigger. And part of the stomach actually shifts up into the chest. So the lower esophageal sphincter is now higher up in the chest, and the diaphragm is separated from the sphincter, because before they were kind of aligned together, and the diaphragm was supporting that sphincter, strengthening this valve. So when that separation occurs, it's much easier for foods to move from the stomach back up to the esophagus because the valve is much weaker. So hiatal hernia is a major mechanism of why patients have reflux.
Mhm. Makes sense. Thank you for that. Looks like we're maybe down to a question or two. So our next question from Caroline, she wants to know, do you see GERD often in very young children?
So I'm an adult gastroenterologist and I do not see pediatric patients. So unfortunately, it's hard for me to comment on that.
Yeah.
I do know that it occurs, but I'm really not the right person to ask that question.
Mm-hmm. Okay, thank you. And Dr. Lammi, so is GERD hereditary? Hereditary, and also she'd like to know, Peggy would like to know, can it be passed from mother to child, or does it not really work like that?
It might be just a little bit of a genetic component in GERD, but overall, we don't usually think of it in that way. It's very much more likely that environmental factors are contributing to GERD more. For instance, the prevalence has increased like by 50% since 1999, and I think that has a lot to do with us with changes in the environment. So traditionally, we don't think of it as a hereditary disorder.
Great, thank you very much. Looks like we got time for very quickly, got about a minute left. So do you find, is GERD more prevalent among certain populations or gender, age, race? I know that you mentioned this on your presentation, just in a few with symptoms, but Sandra would like to know the answer to that question.
So it does. So the prevalence varies. And let me see if I can come up to that slide.
I know you had it with I know like I think it was South Asia, it was 25%.
Right. So we know that in South Asia and Southeast Europe, so I don't know if you're able to share this picture yet, but the red areas is where the prevalence is very high. So in South Asia, Southeast Europe, more than 25%.
Any particular reason why?
I don't know.
Yeah.
I don't know that I actually know the answer to that.
Okay.
Then in Southeast Asia, Canada, and France, it's actually lower than in the United States. And then in North America and in Europe, there is no sex difference, but in South America and in Middle East, women are much more likely to report it.
Interesting.
But interestingly, men are the ones that we traditionally feel will develop complications. So when it comes to risk of erosive esophagitis, Barrett's cancer, it's men that are much more likely to develop these conditions than women.
Wow, very interesting. All right, well, Dr. Lammi, it looks like we're at the 8 o'clock hour. So I would like to thank Dr. Lammi very much for speaking with us this evening. A video of tonight's live stream will be available on the A Women's Journey website, hopkinsmedicine.org/A Women's Journey, under videos on demand. And if you'd enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Women's Journey.org for more information about upcoming live programs, webinars, podcasts, and our monthly email. Good night and stay well.
Thank you so much.
Thank you.